Hi, I'm Rachael and I'm an advanced care paramedic with the Queensland Ambulance Service. This video will be demonstrating and discussing the use of the pelvic binder in the pre-hospital environment. The pelvic binder is a piece of equipment that has been around in various forms for a very long period of time. However, its use in pre-hospital trauma is absolutely paramount. Evidence has proven that the pelvic binder is the primary intervention to reduce major hemorrhage in the setting of a pelvic fracture. Severe pelvic fractures carry with them a high mortality rate, most commonly as a result of massive hypovolemia. Pelvic fracture can also cause damage to the bladder and the urethra and carries a large potential space that can result in a life-threatening uncontrolled hemorrhage. In the setting of trauma, transport to definitive care with an operating theatre and interventional radiography is of the highest importance. However, with the use of a pelvic binder, we can buy some time to get the patient to those places by reducing the potential space for hemorrhage and providing some pelvic stability. In QAS, we utilise the Splints as the pelvic binder of choice. The Splint manufacturers state that their device is the most peer-reviewed device with best evidence to support its use. Clinical trials and cadaver studies were both used to determine the optimal range of force that is required to safely and effectively close an unstable pelvic fracture. The indication for the application of the Splint in QAS is a suspected pelvic fracture with evidence of hemodynamic compromise. Contraindications include a suspected isolated neck or femur fracture or a traumatic hip dislocation. Once the Splint is applied, it is not to be removed, and it is able to stay in situ for CT and MRI, which is advantageous. In pregnancy, SAM Medical does not overly recommend its use, but it suggests that clinical judgment on a case-by-case basis is most important, considering the mechanism and the probability of a pelvic fracture, as well as potential hemodynamics. However, they do state theoretically that if it is applied in the correct anatomical location, it will be able to be used even in late-term pregnancy. In QAS, we carry the two sizes. We carry the small and the large. The small is 69 to 119 centimetres and the large is 91 to 152 centimetres. The sizing has been shown to be accurate in 98% of the adult population effectively, and the Splint does not need to be removed at any time once it is placed on. The most important part of the Splint application is the correct placement of the device. It is the placement itself which supports the use of Splint being successful in closing pelvic fractures of all different origins. In most circumstances, the pelvic binder is laid out on a scoop stretcher or combi carrier, of which you then roll the patient onto, and it is in the correct position underneath the buttocks. That decreases the amount of movement of the patient with application. All objects should be removed from the patient's pockets, and the patient should be exposed with outer garments removed. The Splint should be positioned underneath the patient's buttocks. The anatomical landmark for the Splint is having the buckle in line with the greater trochanter and the symphysis pubis. It is also important to note at this point that the Splint application requires two people. I'll get my second officer here to give me a hand. So for the application of the Splint, we feed the black strap through the orange buckle in line with the greater trochanter. So with assistance, we pull the orange loop and the black, we put pressure until we hear the click, at which point we know we've got the correct compression force. We maintain tension while we secure the black strap to the Velcro strip. So we've demonstrated and discussed the use of the Splint. Now we're going to talk about the concurrent use of a femoral splint. In QAS, we used to use the Donway as the traction device of choice. However, we have now moved to adapt to the CT6 splint, also known as the Carbon Traction Emergency Medical Services Traction Splint. Similarly to pelvic fractures, femur fractures can result in hypovolemic shock, with a potential blood loss of 1 to 1.5 litres from a closed femur fracture, and possible exsanguination with a compound fracture. Application of traction allows to reduce hemorrhage, muscle spasms, and assist in the immobilisation of the limb, reducing limb injury. All of the above can lead to an overall reduction in pain experienced by the patient. However, it's important to note that the application of both of these splints, appropriate analgesia will probably be required. The advantages of the CT6 is that it is able to be used on paediatric patients, patients with bilateral femur fractures, and patients with a pelvic injury. This differs from the Donway, in which in QAS it was contraindicated in patients with a concurrent pelvic injury or with bilateral fractures. The indication for use is a mid-shaft femur fracture. Contraindications are fracture dislocation of the knee and ankle injury. In the setting of a patient with a suspected pelvic injury, the pelvic binder is to be applied first, followed by the application of the CT6. Ongoing assessment of patients with both these splints in situ includes a thorough assessment of hemodynamics, as both injuries have the potential to invoke hypovolemic shock and should be managed as per uncontrolled hemorrhage. Appropriate positioning of the splints. Both the splints should be monitored to ensure they remain in the correct anatomical position and alignment with the appropriate amount of traction. Analgesia. Both splints, particularly the CT6, can cause pain to the patient. It is therefore imperative to continue assessing the patient's pain score and provide analgesia where appropriate. Neurovascular status. It is highly important to continually assess distal perfusion of the affected limb. Neurovascular assessment includes capillary refill, distal pulse, colour and temperature of the limb, and sensory and motor function. The situation of a poorly perfused limb, particularly post-fracture reduction, is a vascular emergency and needs to be transported to a trauma centre with the appropriate facilities with pre-notification. Consideration should also be given for the potential of occult injury, as limb injuries can distract the patient from other sources of pain. Therefore, spinal mobilisation should always be considered and a thorough head-to-toe assessment to look for occult injury. Both of these devices are tools which prevent hemorrhage from two injuries that carry the potential to cause massive hypovolemic shock. Anecdotally, as clinicians, we use our primary survey and highlight hemorrhage under circulation. By this, we immediately control any external hemorrhage while still in this phase of our primary survey. Considering the effectiveness of the pelvic binder and the potential for rapid exsanguination from pelvic fractures, pelvic binder application should occur early in the patient that is either hemodynamically unstable from an unknown cause, patients with a suspected pelvic fracture, or where the mechanism suggests a high potential for injury. It is interesting to note the indication in QAS encompasses only evidence of hemodynamic instability with a suspected pelvic fracture. I suggest the indication for QAS should change, being that it is a device that does not take a substantial amount of time to apply. It is proven to be effective, and it could prevent rapid decompensation if applied early. Thank you very much for watching.